Dueling Perspectives.
Fun. This happens to you. How would you
approach?
At Bascom Palmer, one nice thing is we collaborate a lot.
So I send him both pictures and I say, that's 2023, that's today. Look, there is no change.
Hi, everyone, and welcome to our first episode of Dueling Perspective. I'm your host, Dr. Diana Shechtman. The podcast is brought to you by Fluorescene Media, the company behind ODs on Facebook. Today's Dueling Perspective is honestly near and dear to me. I've always wanted to bridge the gap, and I've been very passionate between ODs and MDs. So this is all about collaborative care. My two guests are not only friends, but are my colleagues who I work with very closely. Dr. Michael Venincasa, he is trained from Bascom Palmer and works with me at Lowell Ophthalmology. And Dr. Stéphane Fitoussi, who you all probably know from Instagram's interesting retinal cases. Is that the correct thing? Stéphane, I just want to make sure I got the right Instagram there. Thank you. And he also is one of the amazing physicians at Blinking Owl. So we're going to get this started. And if you guys like it, please come and join us. I wanted to start with an essence of this particular perspective of a challenge in and of itself can either define you or defeat you, and you can choose which way to go. And I think this collaborative care is going to bring that about. Prior to collaborative care, I think the referral process, and Stéphane, you probably would agree with this, was a unilateral way whereby we referred straight to the ophthalmologist in hopes to get the patients within a year or so back. But nowadays, collaborative care has been embraced primarily because I think co-management has allowed us to pave the way for this. There are a number of ODs growing as the eye care profession continues to grow, but the ophthalmologists have become stagnant or actually decreased. So collaborative care nowadays is not only, I would say, a benefit, but a must. It's a necessity. Let's get started. Mike, why don't you tell me why you decided to go into ophthalmology as opposed to, say, optometry or anything else? And I also want you to tell me, what does collaborative care mean to you?
Yeah, so I think, going through medical school, I knew I wanted to do something procedural in some aspect. And I like the idea of something kind of with a mix. And ophthalmology has a nice mix of surgery and clinic. One thing that's really great is in ophthalmology and optometry, people care about their vision. I think what's the statistic? There's something like 80 or 90% of your brain's use of information is vision, like in terms of like senses. So people care about it. It's easier for someone to do something to see better than to exercise so that their heart is healthy. Ophthalmology has not many emergencies, but at the same time, the eye is a window to disease. So we diagnose a lot of systemic things or help with maybe the primary care physician in working up something systemic. So I liked that. And, about collaboration, I think in general, collaboration is about getting the patient the best care that they need using each person's own specific talents. And I think it's natural to me. I know that we'll probably talk about this in a bit, but there may be more barriers in the past, but I feel like there aren't that many barriers, or at least in my maybe generation of doctors, it doesn't feel like there's a lot of barriers. Within ophthalmology, it's so common. There's so many subspecialties these days that it's just second nature to say, oh, this person needs to go see this subspecialty for this particular procedure. So collaboration with optometry feels like the same thing, a specialist in a different aspect of eye care.
I mean, honestly, that you couldn't have said it better. Even if we were to done this 3 or 4 times, you couldn't have said it better. I basically chose my career now, 27 years ago? I started like when I was 12, but we won't go into that.
Doing the math here.
But nonetheless, I wanted to state one thing that you said is the evolution. It has changed. And you're 100% right. I've been lucky enough to have been here through this evolution of collaborative care. And when I first started, ODs and MDs working within the same practice was unheard of. It was kind of an outlier back then. Nowadays, we see it over and over again in a number of different practices. Fitoussi, why don't you tell me why you decided to go into the optometric world, if you will, as opposed to, say, ophthalmology or anywhere else? And what do you see as a main barrier? Because I'm sure you do have some issues that you have from an everyday basis working in your practice.
Yes, yes. So as you know, my story is quite different from the regular optometrist, and I got to experience optometry abroad with a very different relation with ophthalmology. And I think that's a very interesting point to bring here. When I started optometry, I was back then in Israel, and optometry was really just refractive, and this was it. As you say, the one way to ophthalmology, it was this, and we would never see the patient back again. And I got kind of like frustrated with the fact that I was only refractive and I couldn't really approach that side of ocular disease because even though it was not necessarily my job, but I wanted at least to make sure my patient would be doing well in my chair. And that's why I moved to the US, where I can be kind of like the primary care general doctor of those patients and make sure everything is okay. And in most patients, they're all fine, but once in a while, we have those patients that need further evaluation that I need to send to the specialist. So to me, optometry, I went in this field not exactly knowing what I was getting into. And eventually I fell in love with the profession. And really it's the multi-side aspect of the profession where one day on one patient, it can be a glaucoma patient. After this, it can be a binocular vision problem. After that, it can be just a refractive problem. But like Mike said, this refraction, this vision is a very interesting part of the body. When the patient shows up and he say, "I can't do anything, I don't see anything," and within 3 minutes the patient comes out and he can see 100%, and you just change someone's life with just a simple eye exam.
Great.
And this is really impactful in people's life, and they show up. That can be just I see blurry. That can be I have a headache. That can be sometime I've been having migraines every day, and the solution was refractive correction, or maybe blue light blocking, or sometimes you have those like pink tinted glasses. All of this comes with just an eye exam. And you can solve so many things with just an eye exam. And that's really what I like is the reward that I love when the patient leave the room and they're happy because we found the solution. And it was to me a simple thing. For them, it was something that probably been bothering them for months and months, sometimes years. So really the approach that is very, very much like the PCP. You have the refractive part, the binocular vision, the disease all together. That's what I like about it. And of course, the collaboration. I mean, there is no way around it. Here, I really like the collaboration I have here because when I send a patient, not only I know they're going to be taken care of really well by Mike, for example, and I see them back. They bring me the report. I can see what's going on, and all together we can give the best exam to the patient. And they come to me once a year. They follow up with their, let's say, glaucoma, for example, once a year of the ophthalmologist, and like that the patient gets the best care possible.
And Stefan, you kind of went along those lines. You mentioned about the refractive aspect, and then you still do some of the disease, but you obviously the more complex cases, surgical cases, you refer to someone like Mike or other ophthalmologists. Question here would be, we sometimes see each other as competitors, and I am sure you work with various ophthalmologists who have a dispensary. After all, we're moving more into the medical perspective, we're moving more into some surgical perspective. What do you see as a problem? Would you work with that doctor if they have a dispensary? Do you see that as a competition? Kind of elaborate a little bit about that, because that kind of comes along in collaborative care, but are we competing with one another?
Right. So you have the disease aspect and you have the dispensary, the glasses aspect. For the disease aspect, I really don't think we're competing. I mean, I had a conversation with Mike. We're not competing, and they're so much more, surgical. Their approach is so much more surgical and injections and all those things that we don't, in fact, do. And I like to say it like that. I take care of the basic problem. When he gets a little too high and he requires a little more advanced care, that's not in my hands. And I know it's not in my hands. I know that this patient will do better with Mike than with me, for example. Now, from the refraction standpoint and the glasses, that's a very that's a very good question. I thought about it like this. I think if I send, let's say Mike has a dispensary, if I send him a patient, I expect the patient back. I expect him back for the glasses. However, if this patient never saw me, I'm glad the ophthalmologist has a dispensary. That's great for him. But as long as there is mutual respect and we each other, do our part, and we don't step on each other, I think that's fine. I really don't see any competition between us.
I promise you, if I was your patient, and certainly at my young age, I'm a little bit of a presbyter, just early, I'm just starting right now. I would rather come to you at any given time than, no offense to Mike. Mike,
Name
come
taking.
back to me and let me ask you some questions here. Um, I think Fitoussi brought up a perspective with regards to the patient sending him to you, but I know we've approached this before. Sometimes the patient is a bit confused. Why am I seeing two separate doctors for the same condition? I started in one way and now I'm going to the next. How do you approach this?
Yeah, I think above all, education is the most important thing. So, in general, whether it's with any aspect of a visit, I like to educate the patient really well. I use a ton of metaphors. I make sure they understand what's going on. But I think education helps with respect to OD and ophthalmologist in general as well. Like, if I see someone with a retinal attachment, I tell them the basics of retina surgery, what the met specialist may do, always leaving some wiggle room, because you never want to say, oh, they're going to do this. And then if they say, oh, I disagree, then it becomes, you always leave some wiggle room, but for better or worse, a lot of patients will freely interchange optometry, ophthalmology in the chair. I'm sure it happens on your side as well. And they'll also get confused about the different types of insurances. That's something that I think I want to ask you, Stéphane, about how you deal with. But I usually give a little bit of friendly humor, and just like I don't have any offense, I would get my glasses from you, Stéphane, versus me. But I say the same kind of thing to my patient. Like, oh, trust me, you don't want me to do your glasses. And I say, oh, this is the specialist in XYZ sort of thing. Just like you'll say, oh, this is the specialist in whatever, glaucoma, whatever it is. And that usually goes over pretty well. One thing we also do is whenever someone makes an appointment, we always make sure to make a point of telling them, oh, by the way, we don't do glasses, we don't do contacts, because sometimes that's all they're looking for. And the last thing you'd want is them to show up, take the time off of work, get there, get their vision checked, whatever. They're like, oh, I'm just here for glasses. And like, oh, you guys don't do it. And then they're going to be upset. But like along those lines, I think patients are always confused. I'm confused too. I don't know what covers what, but patients are always confused about medical versus vision insurance. And I learned about this recently, because I was in the medical side my whole training, and so I've been out for about 2 years now, and I recently learned, okay, vision, it covers this, and there's rules like a vision. If you start the appointment as vision, it has to stay vision. It can't, you have to bring them back a separate day to be medical. Like, it seems natural to me. It would be like, oh, if you start off as a vision screening and they say, I have blurry vision, and you start out with a refraction, and then you find out that their refraction is minus whatever because they have something going on the retina, it seems like it can transition to medical. Stéphane, like, how do you deal with that patient? Or like, also, like, that they need some sort of workup. Maybe you say, oh, that nerve's a little suspicious. I'd like to do a glaucoma workup, but they're in a vision plan. How do you deal with that stuff?
There is just so many ways to approach it. Listen, the patient walks in, they really think there's one eye doctor for everything. And like you say, they don't know who is what. This morning, ask the patient, when was the last time you saw an ophthalmologist? They say, well, last year. Oh, yeah, who was it? It was you. And I'm like, well, no. You see, even them, they're confused. They don't understand. So I most of the patients, the majority of the patient, they know how to differentiate between the vision and the medical, but you still need to explain. 99% of my patients shows up because they think they need glasses. And out of those, well, there are a bunch of diseased patients. Once I identify the disease problem, number one, I give them their glasses, and number two, I send them to you, for instance, and I explain to them, this is going to be medical evaluation. Oh, can I use my vision insurance? Well, this is different. And, it's very simple. We know it's simple. It's refraction, it's vision. And as soon as it affects your health, I guess we can do it like that. That's the medical insurance. I personally I can't treat medical problems on vision insurance. It makes no sense. But we do have those medical visits. For example, patient shows up with flashing lights and floaters. I'm not going to say go away. So what we do, we charge a separate fee, for example, just for medical visits. But it's something that can just be done one time. I can't do a glaucoma patient, for example, and follow up over the years with just out of pocket medical visit. It doesn't make sense. So as long as it's something that is quick and is short, I do one single medical visit. If I see something that requires more extensive care, like glaucoma, I just refer them and I'll let you take care of it from there. Yeah.
And I think you brought up a great point because everybody, there are doctors out there, optometrists, who feel very comfortable with glaucoma. They have the diagnostic modalities and they manage it up to a certain level. But I think with Mike, you became an ophthalmologist, and that's why I kind of wanted to get the feel for it. Also, as a surgeon, you love surgery. And if I can keep you more in the surgical perspective, screen the diabetic retinopathies that are not really there, just as a screening diabetes and so on and so forth. Or like he said, flashes, floaters, he determined everything was fine and didn't need to go to the next level. It makes it easier for you to really stay managing the complex cases, the surgical cases, and so on. So that really, in my essence, is true collaborative care. And I wanted to bring something back because you both discussed it, and I'm really intrigued to find out from you, Venincasa, first. You said you've been out for just a couple of years, and I am certain that maybe your mentality, your thoughts of collaborative care or what optometrists did may have varied and changed from when you first went into medical school and then when you got out, especially when you went to Bascom Palmer and you worked side by side with optometrists in and of itself. There's still a historical tension and a lack of understanding of respect between both professions. I'm not saying one way or the other. So why don't you share a case or a time, good, bad, or indifferent? I'm sure Fitoussi will have his own to share at Bascom Palmer when you work side by side with some top optometrists as well as ophthalmologists as to
Yeah,
how you change your thought process about collaborative care or what we did.
yeah, absolutely. Now, just realized something. We talked about my refraction. Speaking of Bascom Palmer, the person who taught me refraction was none other than Stéphane Fitoussi.
Oh my
So
I
goodness.
saw him
Well,
day
we have to
one,
call it
week
that.
one, walking into
His head just
ophthalmology.
got this big. He's now
No,
called
we
Professor
know, I know
Fitoussi.
this story.
so
I don't, so I'm dying to find
That's
out.
how we
But
first met. He was refraction, and
please
it's
tell
something
me how
very
you
dear to me. So
first met Professor Fitoussi. I'm dying to
it,
hear now.
it was a lecture. So at Bascom Palmer, one nice thing is we collaborate a lot. I mean, so much that optometry gives us lectures on how to refract. Optometry often comes to our morning lectures of ophthalmology, retina conference, whatever it is, especially if they're particularly interested in that. I mean, through the ER, I mean, they're just countless cases. And I would say things have even changed for the better since when I was there. When I was there, they had rolled out optometry helping with inpatient consults. Stéphane, you were on that side of it, so you can maybe give your thoughts. Since then, they've have rolled out even more help in the ER. Now there is a attending optometrist every day of the week. That was something that they started, I think, maybe 3 times a week when I was there. Now, including even weekends. Optometry residency, I know it's expanded since I was there. I think they added one more slot, and that actually allowed them to have even a night shift optometry resident that will see the overnight emergencies with the ophthalmology resident. So, I mean, those kind of things, like some things you see there are like only in the textbook kind of stuff. So I'm sure that's some great experience. But it was great. I mean, every day you're working side by side. Now in the ER, like you said, you're trying to you said like surgical, non-surgical. In the ER, the optometry resident and attending would focus on the non-surgical stuff. They would see the dry eye or the chalazion or the glaucoma suspect person, whereas the ruptured globe they would leave for the ophthalmology resident to prep for surgery and stuff like that. So it was a great system where you work together, you share patients, and then sometimes it would go, from one to the other. Oh, hey, I saw this person. I thought it was going to be dry eye. It's actually a ruptured globe, and they would, kind of share things either way. So, but Stéphane, how did you feel about that experience?
you know what? I was apprehensive when I came to Bascan. I'm like, I don't know what to expect from ophthalmology. Yeah, they're gonna treat us differently because we're not the same branch. And you know what? I didn't feel that one time. We would work, usually the ophthalmology resident or the fellow and us, and we would do a very similar job, seeing the patient, then the attending comes in, and even the attending, they would treat us the same. And we would learn together, and it was great. So when they needed us to help, for example, in the neuro clinic, optometry was great because we needed to measure the deviation, the prisms, all this. That's our job. We know that great. And sometimes when we needed to look at an MRI, for example, I go to ophthalmology. I'm like, listen, I have no clue what's going on. Help me out. And the collaboration here was great. We was really helping each other. And like you say, in the ER, it was we were doing the same job and we were separating what needs a little more attention, all those detachment, etc. They were going to the ophthalmologist, and when it was something like a little simpler, it would go to the optometry resident and the inpatient visit. I think it was great. It was a great way to expose us to something different. They used to have the fellow that would take care of those inpatient, and they found out that if they put the optometrist first, so we would go and kind of like screen and have like the first impression of the patient and then report to the fellow or the resident of ophthalmology, and together we could make a decision. This was great, and the fellow and the resident, they were always 100% with us. I mean, like I said, it was a fantastic experience. Not one time I felt any competition. It was great. It was really great.
And, I didn't really realize this until maybe now, honestly. Thanks for sharing your story about like how it was abroad. I know that residency is ocular disease residency. And to me, I guess I never really thought about it that way, is it wasn't always the case that you would learn ocular disease. Sometimes it was just refraction. And then if you so wanted to, you'd be say, okay, hey, I want to do ocular disease. It seems like kind of natural to be like, oh, that's just part of learning. But that's it's cool to see that,
Because you see a patient as a disease patient,
yeah.
and you probably think a lot of the patient have disease. Well, I can tell you the majority of the patient don't have disease. 90% need glasses, and once a day you get a patient with a suspect for something. That's more reality, and our approaches are very different.
That's such a
Um,
great point.
Yeah, that's
Such a
interesting.
great point.
Because
Very unique.
even the ratio, I would have thought it's much skewed the other way. So because what I see is referral for suspect, suspect, suspect. I'm like, oh, they must be seeing these things all the time. But to hear that it's one or two a day, that makes sense.
when I was at Bascom Palmer, I thought everyone has glaucoma.
That might be
And
true.
right now, I can say maybe I see maybe once a day,
Yeah,
less, once every other day, a suspect, not even a definitive glaucoma.
yeah.
Yeah, so the
Where
approach is
patients are
very
coming
different.
in with that's a really good point about the whole perspective of how we see things. And now when we're talking there with at side by side, you're working at a place like Bascom Palmer, a major institute at hand. But if you're separated, you're not working side by side, but you're still working with one another. Just like you said, there are different perspectives and there's got to be different needs as well. So why don't you let's start with you, Mike. Why don't you tell me what do you think should be your needs that you need Stefan to address when sending a patient? What are things that are important to you to address?
Okay. In general, I guess I'd say most things are okay as a rule out XYZ diagnosis on a prescription pad.
Simple
That,
diagnosis,
that
nothing
usually tells enough. Rule out Fuchs. I know what I need to do. But there are some things where getting some history is helpful. Getting a best corrected visual acuity on your end, say, I already tried the refraction and I got this, and this is helpful. For a high pressure, a glaucoma suspect, it's helpful to know what was the pressure. A single reading of 24/24 is different than 40/40 or 40/15. Or if you started some drops, what was it before? But that's true anywhere. That's basically any glaucoma patient that ever transfers care. If they don't have the records, it's like, well, I don't know if 15 is good for you or if 15 is too high. The other thing I guess would be like worsening blank. Like if it's a lid lesion, for example, some measurements, maybe a photo or something like that, an old picture. Otherwise, it's impossible to know kind of how things are changing. But otherwise, large nerve glaucoma versus physiologic, you know what you need to do. Suspect Fuchs, you know what you need to do. But I like the info. I always look at the notes. They in our practice, it's great because they have like a liaison. And Diana, you also are our second liaison basically. But
It's
we'll get
really important.
emails, photos like of notes, and I'll go through those. I'll see the patient like I remember that name. I'll go back into my email and look at the chart note. Like, okay, here's what they found on this day, this day, this day, and that's really helpful.
Stefan, what about you? What do you need from him?
Would be great to know what's going on first. Like I told him earlier, I usually have the patient and I start from scratch. And the patient, they don't know what's going on. They're like, oh, I saw the ophthalmologist. Why is that? Oh, I have a detached cornea. And it always comes like that, and we don't know what's going on. So
It's true.
it would be great. Me, when I get a patient back,
You can
I'd
know.
love to know at least the diagnosis. What's the plan? So then I know the refraction, the VA. I'll figure it out myself. But at least to know a good idea of what's going on and if I need to do something about it. Yeah, it's pretty much it. When I send the patient to him, I make sure, like he said, I make sure to attach the most useful information regarding his treatment. For example, I had this patient, she was glaucoma suspect. Better than glaucoma suspect, the CD was like zero point 0.7, and I can see the wedge defect. Straightforward here, there's glaucoma. I don't need an OCT, I see the wedge defect. However, I had a picture of 3 years earlier, the nerve looked exactly the same. So I sent him both pictures and I said, that's 2023, that's today. Look, there is no change. Maybe he's going to treat differently now.
But
Yep.
Tuesday, I actually, by you bringing that point, it reminded me of a case you and I shared, which was fantastic the way that you send your records. We had that atypical choroidal lesion, and it was small, under three disc diameters, or maybe just about three. It did have lipofuscin when we saw it, but the key fact that you had the pictures from previously and the
Yes.
secondary picture a year later with the documented growth was critical in regards to how to manage that patient, whereby maybe just having a three disc diameter lesion doesn't seem that
Because
worrisome.
it wasn't impressive at all. The lesion
Right.
on itself was not impressive, but the change
That's a
was
great
really,
example of true
yeah.
collaborative and making a difference on the management of that patient. And basically, how your initiative, you're not needing to be the treating doctor, but your initiative is still saving her life. So, it's kind of like having the catalyst and the enzyme. I kind of always use that perspective. And there's a big point of what you initially identified and move forward. So, collaborative care is adopted across all aspects, and kind of want to finish this up and wrapping it up here. But collaborative care, I think it's really across all aspects of care. You have a primary care referring back to an endocrinologist, cardiac with a surgeon and such. But bringing back a point, because this is part of ODs on Facebook, I remember Alan posted, and there was quite a bit of an uproar with this. He posted a little chat that talked about him having his favorite cataract surgeon and sending all his patients, but then he realized that many of his patients, even the ones that he referred as cataract patients to this surgeon, were being sent to other opticals or other places at hand. And so, how should Alan approach this? Stefan, this happens to you. How would you
I
approach
would
it? Do you
delete.
let him go, forget it, I'm never referring to him again? How do you do this?
Listen, it's very frustrating. How can you send a patient to someone else? To me, it's very straightforward. I put an X on that ophthalmologist, I move on with the next one. There is no other way around it. How can you send a patient to someone else when I created
A
that
referral
patient to
path.
we have a lot of options. Cataract surgeons are not missing. So I think it's just respect. It's just respect to send back the patient. Um,
Hold that thought. Hold that thought. Mike, let's go back to you. Looking at it from a different perspective. It could potentially happen to you without you meaningfully sending the patient out. So why don't you give us your perspective of what could potentially be happening or
Yeah.
could have happened in the past?
So, if it's, I completely agree. If it's being intentionally done, not right. I'll say that sometimes I struggle with knowing that the patient's going, forcing them to go. And there are some things that are helpful with that. Number one, a good EMR. Our EMR thankfully keeps track of who referred that patient, so I can very easily know who to send it back to. Otherwise, it can be tough. If you're seeing all these different cataract evaluations, doing all these different surgeries, it may be tough to know which one came from which doctor and when it's time to go back. So that's number one. That lets me send referral letters back saying thank you. Okay, here's an update. They're at week 1. They're doing well. We're about to do eye number 2, etc. But one thing that I started thinking about is maybe those letters aren't enough. And because I'll tell the patient, go back and see Dr. Fitoussi. But maybe I feel like it's less common from my side to send the referral pad to send the text message, to talk to the office, to make sure that they get scheduled. And maybe that's because the refraction isn't an urgent thing. Like it's not a life or death thing. Whereas it's, oh, this nevus getting worse. I need to make sure this gets seen. But at the same time, it's just as, I mean, it's also very important. So lately I've been trying to send text messages actually to the office, like the office coordinator, and be like, oh, like this person's interested in getting glasses or whatever. Because when I send the letter back, that requires, I guess, I mean, I'm sure you get tons of referral letters each day. And so that you don't have to sit there and go, okay, is this one for they're at week 1, or is this one for, okay, it's time to schedule them for a refraction? It might not be enough just to send the letter back. It might be a text message to you saying, hey, this person's ready. And tell me if that's what would be helpful for you to make sure that patient gets scheduled. Is a letter enough, or what should an ophthalmologist do to make it? Because I have, sometimes it's no control. You say, oh, go back and see Dr. Fitoussi. You know, for better or worse, sometimes, you know, they're just so happy with their vision that they're like, I don't need glasses anymore, Dr. Venincasa. No, but you know, sometimes they're like, oh, I got a pair of over-the-counter readers, and I'll see them back and like, oh, did you go get a new pair of glasses? No, I have readers, I'm good. And it's like, I don't want that to come back as, oh, I never tried to send them back. What would be helpful on your end?
There's just so much you can do. Listen, I feel like it's my responsibility when I send them to make sure they understand that they need to come back yearly for their glasses. It's my job. When they leave, let's say, because again, they're confused of who's taking care of what. So when I send them for glaucoma suspect, for example, they think we transfer the whole thing over there.
Yeah.
And
That's a good
okay,
point.
I'm going to see this doctor and he's going to take care of everything. And by the way, he's the specialist, so he's probably going to make better glasses. That's how they see it, right? So I make sure for them to understand, listen, your glaucoma suspect, you need to see this doctor to rule it out or to start the care with it. However, you need to return once a year here for the glasses. So I'm your glasses doctor. That's your glaucoma doctor. You see us once a year or once, however we decide. But you need both together, and I make sure they understand.
Yes.
Because once they see you, you know, they don't know anymore. They really don't know. I don't know if there is much you can do for them to come back. We do our year recall anyways. So maybe when you just send me like a fax or like a feedback on how's the patient doing, I'm like, oh, okay, maybe it's time to send a text message to the patient. Hey, it's your yearly exam. Please make sure to come visit us.
Maybe I'll start putting at the very top, ready for refraction, and then the note, because
Right.
usually that stuff is at the end or something. But it usually comes
Yeah.
with a letter. Oh, thank you for sending. One thing you do a great job with it, but it is sometimes tough to know how much optometry wants me to do. If they have
Good point.
glaucoma suspect, there's an OCT, they sent a visual field, they're referring for glaucoma suspect. It's like, well, they have the equipment. If I think that it's not glaucoma,
It's the insurance. Again, it's the same thing. It's vision insurance. What do you want me to do on vision insurance?
well, but sometimes they'll have all the testing, and it'll be someone that I know is comfortable with glaucoma. So sometimes you're good with it. You make it clear, like, here's what I can do, can't do with in the clinic that I have. Here's the machine that I have and don't have. But sometimes optometry will be on medical plans as well.
Mm-hmm.
And it's tough to know, just like the patient doesn't know. Sometimes it's tough to know who's on what. Insurances are always changing. I mean, I feel like that's one barrier that should come down is optometry getting on medical plans, because these days you do medical stuff, like everyone almost does medical stuff.
Mike, but the one thing, and I think we both brought up a great point, and I think we're going to kind of finalize with this, is the fact that it's not just about the insurance plan; it's also about people's comfort level.
Yeah.
You are a comprehensive doctor. You're not a glaucoma surgeon, but you can certainly work and evaluate and assess glaucoma, even MIGS, but you're not doing TRABs, for example.
Yeah.
When it comes to optometry, we're kind of jack of all in a way.
Yeah.
We do a little bit of everything, and there's some people who like to subspecialize in particular areas of disease. But how do you know who wants to manage a glaucoma patient or not? Or say a patient has glaucoma, in you're a retinal specialist, patient has a retinal problem, but they also have glaucoma. Should they be sending back or not? Because certain people may not be able to see it because of an insurance, others because of equipment, others because they just don't feel comfortable. So it makes it really hard from both ends, which I think it ties everything together where respect and communication is key, particularly with those doctors that you work very closely. remember at the beginning, as I talked about the quote in and of itself, it's easy to let a challenge, just like Stéphane said, challenge what Alan talked about. His favorite cataract surgeon was not sending the patient back. Put an X, never see it again. But that's kind of almost defeating you. Why? Because you just walked away from the whole thing, as opposed to taking a step back, let it define you. Why don't you make a call, especially if this is a doctor you work for years, and find out what the problem is? Like Mike mentioned, maybe your name wasn't written on there. Patient felt like there was no need to go back. They're seeing great. They don't need a refraction. Whatever it may have been, maybe by having a communication and opening up those doors, we have a better collaborative care. So bringing about, why we should be working with one another. So I wanted to thank you both so much for such a great conversation at hand. I look forward for other dueling perspectives and hopefully having both of you again.
Thanks so much for having us.
It was great. Thank you for having us.
Thank you to our guests for joining us today and sharing your insights. Thank you to our listeners for tuning in.